My name is Caroline Lozer. I'm with the Lewin Group. Welcome to the webinar, Safe and Effective Use of Medications in Older Adults. This is the first session of our 2018 Geriatric Competent Care webinar series. Today's session will include a 60-minute presenter-led discussion, followed up with 30 minutes for a discussion among the presenters and participants. This session will be recorded, and a video replay and a copy of today's slides will be available at our website, www.resourcesforintegratedcare.com. The audio portion of the presentation will automatically stream through your computer. We also have phone lines for this presentation, and to access the phone number, you can click the black phone widget at the bottom of your screen. Continuing medical education and continuing education credits are available at no additional cost to participants. AGS is accredited by ACCME to provide continuing medical education for physicians and by NASW to provide continuing education for social workers. CMS is also accredited by IACET to issue CEUs. So you'll see on this slide that we've laid out the various continuing education credit options. If you're a social worker, you could obtain continuing education credit through NASW if you complete the pre-test at the beginning of the webinar and complete the post-test. If you're a physician, you could obtain CMEs through AGS if you complete the pre-test at the beginning of the webinar and complete the post-test as well. And CMS is also offering CEUs for other individuals looking to obtain credit for attending this webinar. In order to obtain these credits, you must complete the post-test through CMS's Learning Management System. Additional guidance about obtaining credits and accessing the links to the pre-test and post-test can be found within the Continuing Education Credit Guide in the resource list on the left side of your screen or at the Resources for Integrated Care website. This webinar is supported through the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar series. To learn more about efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. So at this time, I'd like to introduce our moderator. Carol Regan is a Senior Advisor to Community Catalyst Center for Consumer Engagement in Health Innovation and has over 30 years of experience with national and state-based public policy and advocacy organizations. Carol?
Thank you, Caroline, and thank you, Medicare and Medicaid Coordination Office and the Lewin Group for continuing to sponsor these incredibly rich, important series. Community Catalyst has been very engaged for several years now with these partners and the American Geriatric Society in promoting and exploring good models of care for older adults, and particularly dual eligibles and those with complex care needs. So we're really delighted to be supporting this and involved in this effort. So let me introduce an distinguished faculty, and then we'll turn it over to them soon. So you can see on your screen, we've got four speakers today. Todd Semla has a master's and doctorate of pharmacy. He's a national PBM clinical pharmacy program manager, mental health and geriatrics for the U.S. Department of Veterans Affairs. And an associate professor in the Departments of Medicine, Psychiatry, and Behavioral Health Services at Northwestern University's Feinberg School of Medicine. He's a fellow, a past president, and a board chair of the American Geriatric Society. And since 2009, Dr. Semla has co-chaired the AGS Beers Criteria Panel, which produced the 2012 and 2015 updated criteria for inappropriate medication use in older adults. And you'll hear more from our speakers about the Beers criteria in today's presentation. The next speaker is Dr. Thomas von Sternberg, who is a Senior Medical Director of Community Senior Care, Home Care, Hospice, Government Programs, and Care Management at Health Partners, which is a Minnesota-based health plan serving nearly 1 million members, including 50,000 Medicare participants. He's board certified in geriatrics and family medicine. In his role as a senior medical director, Dr. von Steinberg develops and coordinates programs for the geriatric population with emphasis on frail, complex elders, Medicare Advantage, and the dual-eligible population. He's involved in coordinating care of the care system's home care, assisted living, and post-acute transitional care network patients. He oversees the home-based medicine service and supervises the home care agencies within Health Partners and services related to hospice, palliative care, and end-of-life care. He's a member of the Faculty of Geriatrics at the University of Minnesota Medical School, a medical director for a long-term care facility, and a member of the Minnesota Nursing Home Medical Directors. Finally, Dr. von Steinberg was the past medical director of Seniors Plus, which is a social HMO. And our next speaker will be Donna Fick. Donna is a distinguished professor at the Penn State University's College of Nursing, an endowed professor of nursing and director of the Penn State Center for Geriatric Nursing Excellence. She's a member of the interdisciplinary panel for AGS's Beers Criteria and serves on the American Geriatric Society Board. She currently serves at the National Academy of Medicine, their Forum on Aging, Disability, and Independence. Dr. Fick is an internationally recognized as a leading expert in geriatrics, and she's been the editor of the Journal of Geriatric Nursing and is board certified as gerontological, clinical nurse specialist and a fellow at the American Academy of Nursing. And then finally, we're pleased to have Maricillas Tejeda. She's a senior health coach with City HealthWorks in New York City, where she started in 2013. Maricillas was born and raised in Santo Domingo, Dominican Republic, and specializes in diabetes, asthma, hypertension, and congestive heart failure health coaching. She works one-on-one with her clients in their homes or in the community and teaches them to set and meet personal health goals. She identifies and helps clients address social needs and accompanies clients to their doctor's appointments and help them navigate the medical system. Maricillas attended LaGuardia Community College for a community health workers certificate. So you can see we have a rich array of speakers today. And let's move to the polls next, and then it'd be my pleasure to then turn it over to Todd Semla. So we always like to get a sense of those of you on the phone and where your background is. So you can see this following question: which of the following would best describe your professional area? And just pick one. You may have multiple ones, but if what's your primary professional area? And just click that box. Okay, 10 more seconds. Great. Okay, let's see the poll. Great. Okay, yeah, so we can see a wide variety of folks, a lot of medicine, clinical providers, some health administration, social work, health plan management staff. Wonderful. Great. Next poll. So in addition, what would you describe as your primary role? We have a list of different roles and occupations. So what did you say is your primary role in your work? Wonderful. Okay, a couple more seconds. Just pick one. And great, let's go to the next summary and see what we got here. Okay, wonderful. Oh, we have, like in the past, we have a lot of care coordinators. Great. It's consumer advocates, clinicians, administrators. Wonderful. Great array. Thank you. And our last poll, describe the setting in which you work. So for some of you who may work in multiple settings, again, what's your primary setting and where you work? You can see a list of choices. A couple more seconds. Great. Okay, let's see the results of this last poll. Great. Wonderful. So we've got almost half, 42% from a managed care organization, a number of community-based organizations, long-term care facilities, and ambulatory care settings. Wonderful. So thank you. So you can get a sense of the variety of folks and their professional backgrounds on the phone. So let me turn it over to Todd Semla. Todd?
Thank you very much. Good morning or good afternoon, everyone, depending on where you are. Could we please have the next slide? So these are my disclosures. I will only vocalize one, and that is that the views of the presentation are my own and do not necessarily reflect those of the U.S. Department of Veterans Affairs or the U.S. government. Next slide, please. Next slide. Okay, I think we skipped one. We need to go back one. There we go. Thank you very much. So we're concerned about patients who are dual eligible for Medicare and Medicaid. They account for about having about 25% higher rate of chronic conditions than beneficiaries who are not dually eligible. They also tend to use a variety of medications and have a higher Medicare Part D prescription drug cost than Medicare-only beneficiaries. So this is a particularly important group to focus on and talk about. The next slide, please. And this shows how many of the ways that dual eligibles are different from non-dual eligible Medicare beneficiaries. They tend to have twice or higher the rate of being cognitively or mentally impaired. They have 3 or more chronic conditions more often. They tend to rate themselves as being in fair or poor health more commonly. They require more assistance with 1 or more activities of daily living. And they're also more likely to be a resident of a long-term care facility. So next slide, please. I like to show this slide because it shows the trend that we've had in the United States in looking at medication use, particularly prescription drug use, by persons over the 65 years and older. And if we go back to 1968, you'll see that approximately about 25% of the population was 65 years of age and older, and they purchased around 10% of all the prescription drugs sold each year. If we move ahead to 1981, we see that the U.S. population was about 31% senior, and they accounted for around 12% of prescription drugs sold. And if we fast forward to 2040, it's anticipated that the U.S. population will be somewhere around 50% 65 and older, but they will will be about 25%, but they will purchase around 50% of all prescription medications. So as the population ages, so does their percentage of prescription drugs purchased in the U.S. Next slide, please. There are a number of factors that influence medication use. There are individual characteristics, who we are, if we're a man or a woman. Women tend to use more medications than men. They're better at going to the doctor and seeking help than men, who tend to be more stoic. There are also physiologic changes that separate us from one another, such as how our kidneys function and drugs we would need to avoid or not use, so that can affect which medications we get. The disease states we have, as we've already noted, the number of chronic conditions goes up as we increase with age. Those will also dictate an increase in use of medications. And then there are sole conditions that require treatment oftentimes with 1 or more medications. Diabetes, hypertension, and heart failure all could be managed with 1, 2, 3, or even 4 medications, depending on the severity and the goals of trying to treat. There are psychosocial attributes, and particularly in the U.S., we have this philosophy of a pill for every ill. We tend less likely to want to go to psychotherapy, for example, for depression and anxiety, would rather take a medication for that. Physicians also influence a great deal of the medications that are used in the United States or prescribed to individual patients. And in fact, physician-to-physician communication is the #1 influence. It's not the drug company representative, they're #2, but it's actually the peer-to-peer contact that physicians have. Advertising is also something that is extremely important in terms of how we're influenced by which medications we take. This often has increased greatly since the direct-to-consumer advertising has taken place in the U.S. in the past 15 or 20 years. And in fact, the pharmaceutical industry has shifted its resources more towards direct-to-consumer advertising and less to actual salespersons out in the hospitals and doctors' offices. So next slide. Okay, you can advance it. There we go. So this is a couple examples of what we call prescribing cascades, which is something that we teach physicians, pharmacists, nurses, anyone working with older adults and their medication to be on the lookout for. And it's often referred to starting one drug to treat the side effects of another drug. This is a form of polypharmacy. So you could say that you had an older gentleman who has experienced some back pain, doing some work around the house, and he has pulls a muscle. So he starts to take over-the-counter or ibuprofen, Motrin. Now, Motrin has a renal effects, kidney effects in older adults, and it can result in an increase in blood pressure, on average about 5 millimeters of mercury systolic blood pressure per person. So they're taking this, and they see their physician, and who's kind of been watching their blood pressure because they're concerned that they may become hypertensive, and they notice that they are, in fact, hypertensive, and they prescribe them an antihypertensive, amlodipine. Now, amlodipine has a side effect that will cause lower extremity edema, and that's also noted the next time the person comes back because they say, look, doc, my blood pressure is better, but my legs are all swollen. So they give him a diuretic, furosemide, which gives the gentleman urinary frequency, and he has an enlarged prostate, but had been manageable, but now he's given a medication to treat his enlarged prostate. So instead of perhaps being on no medications if he had gotten limited treatment or something else besides ibuprofen, then he's now on 3 different medications. And even if he stops the ibuprofen, it's unlikely the other 2 would be, or 3 would be stopped. So that's what we call a prescribing cascade. Another example that we're always concerned about is a patient who's taking medications that have anticholinergic effects. We'll talk a lot about this later in the presentation. But these medications can cause cognitive impairment or delirium, and this could be misdiagnosed as someone having dementia and result in prescribing an anti-dementia medication such as donepezil, which is a cholinesterase inhibitor. So again, a patient's on one medication and it leads to a side effect and they get another medication, and it's likely to be a chronic medication. Next slide, please. What are the consequences of inappropriate use of medication by older adults other than leading to more medications as we've shown? Well, it's been noted that this increases the likelihood of death, mortality, morbidity such as hospitalization or seeing more office visits, perhaps falls and fractures. If the medication is inappropriate, it results to that, and other adverse drug events such as delirium, as I've mentioned. It increases healthcare costs and utilization because of these events need to be treated. There's also an increasing use in the oldest and most vulnerable adults that we see inappropriate medications being prescribed. And one of the concerns is that the more medications you are on, the more likely you are to be on one of these medications we consider to be inappropriate. So that's always a red flag, looking at the number of medications the patient's on and trying to see if any of them are inappropriate. And even though inappropriate medication use is highly common, it is preventable with rigorous monitoring of the patient's regimen and determining what, in fact, they need. Next slide, please. The latest statistics we have on inappropriate prescribing in the community is about 41% of elderly that live in the community are prescribed at least one inappropriate medication using the 2012 Beers criteria. And the NSAIDs are non-steroidal anti-inflammatory drugs like Motrin or ibuprofen, I mentioned earlier, accounted for 10% of this inappropriate use. And then benzodiazepines, which would be drugs like Valium, accounted for another 9%. Next slide, please. Drug-drug interactions are also things we're particularly concerned about. And I'm going to point out to a couple of them that appear in the most recent version of the AGS Beers criteria. And the first is that the use of 3 or more drugs with central nervous system effects. So this is sort of referring to CNS polypharmacy, and it could include medications such as the antidepressants, the SSRIs, selective serotonin reuptake inhibitors, such as Prozac and Paxil, or Zoloft, Celexa, a tricyclic antidepressant, some of the older antidepressants, the use of an antipsychotic, benzodiazepines, And then what we call the Z drugs, which tend to be other non-benzodiazepine medications used for treatment of insomnia, are examples. And then also a combination with opioids. So any combination of any three of these are a concern that because it increases the risk for falls in older adults. In many of these drugs, even by themselves, are linked with falls, but combining them with two or more other CNS active agents further increases that risk for falls. And then prescribing of multiple drugs with anticholinergic activity, and this leads to increased risk for impaired cognition or delirium, as I discussed in the other example. So we'll show you a list here on the next slide, please, of medications that have anticholinergic activity. And this is something that I point out because these medications are available over the counter. A lot of the anticholinergic effect is not the intended benefit of the medication, but it's a side effect. So it's kind of hidden in a lot of these medications. So, for example, the drug meclizine, which is Antivert, which is sold over the counter to treat vertigo or as an antiemetic. Many of our antispasmodics that are used to treat urinary incontinence, such as oxybutynin, is another example. These medications are found in both prescription and non-prescription over-the-counter cold and allergy drugs, such as hydroxyzine, and diphenhydramine is Benadryl, which is also found in sleep aids. And then skeletal muscle relaxants and some of our tricyclic antidepressants are also strongly anticholinergic. So it's a wide variety of types of medications that have this effect, and they can be rather insidious and creep up on people and put them at risk for cognitive changes that people don't often attribute to the medication. So next slide, please. So older adults are vulnerable to these because they have a high probability of exposure. They have greater sensitivity due to some of the physiologic changes. And if they have pre-existing cognitive impairment, they're at much greater risk for further worsening of that or even delirium. Next slide. Well, what can be done? Well, we've tried some regulatory mandates, particularly OBRA 87, which goes back to nursing home regulations, which really tried to disallow the use of antipsychotics and some other medications to treat some of the behaviors in patients with dementia that they were shown to be harmful and really not beneficial. Those regulations have been revised, but they are still there in different format. The AGS-Beers criteria I've mentioned several times, and this is something that's used by CMS and insurers to reduce inappropriate prescribing, often initiating a prior authorization if you want to use one of these medications in a patient over 65. Medication reconciliation is another thing that's mandated by JCAHO. It's very useful in transitions of care. Drug regimen review and cross-check, looking at patients' medication list, having them show you everything that they have in their house, having either in person or by a list of medications and cross-checking that with what they're supposed to be taking in the chart. And then another useful item that can be helpful is to actually chart out all the medications and all the different times a day the person has to take their medications, showing it to their providers, because oftentimes these regimens can be simplified by reducing medications, and that can be very helpful. Next slide. So a little more about the AGS-Beers criteria. It's a free resource. You can find it at the web link at the bottom of the page, geriatricscareonline.org. There's a lot of information on those pages, such as how to use the criteria, what they actually mean. There's an alternative medication list for some of the Beers medications. There's a pocket card, an app, and then there's also public education resources that you can give to patients or their caregivers for things that they should know about medications, keeping a medication diary, tips for medication safety, and other things that they should be aware of. So there's a very valuable resource for them at geriatricscareonline.org. Next slide. Another criteria that was developed in Ireland and is used in Europe, but it's made its way into the United States that some people like, are the STOPPISTART criteria. They're very similar to Beers in terms of the medications that should be stopped or avoided, as we say with the Beers criteria. But they also have medications that should be started. In other words, they reflect the underprescribed medications that are often not given to older adults because of concerns or oversight. So it's a very complementary list to the Beers criteria. Next slide, please. Deprescribing is something else that's very helpful. It's a big buzzword right now, and targeting medications that don't have an indication are no longer needed, they're not working, that are duplicate or are not being taken or adhered to. So next slide, please. And these are events where deprescribing could be triggered: care transitions, annual review of medications before a new one is started, if there's a new problem that's cited as a drug-related problem as opposed to something else. And it's very important when you're deprescribing to educate patients and their caregivers about what's going on, so they have instructions, they know to monitor, they don't freak out if they have a withdrawal phenomenon or their condition is exacerbated, so what to expect. Next slide, please. These are medications that are primed for deprescribing. Many of these are on the Beers list we've talked about. Others are medications who you have to look at what the patient's goals are, perhaps as they get later on in life, their goals in terms of what they want, and the benefit of the medication may have diminished or their disease has advanced and the medication is no longer really being helpful. So those things should be, these are examples of those medications. Next slide, please. So as I said, the deprescribing.org, it's out of the University of Toronto, I believe, and it's all free resources. There's wonderful algorithms for providers, and there's also brochures and things for individuals to get more involved. Okay, next slide. And then screening and medication review is something that should be done regularly, at least annually, when starting a new medication or changing a dose. You could do it more often, but to do a medication review, and this is often done in collaboration or by the pharmacist, to look for drug-drug interactions, identify all the medications the patient's taking, and any medication problems that the patient's having, such as adherence. Next slide. And this is a summary slide that shows how deprescribing adverse events and drugs to avoid all kind of overlap. This is all kind of a continuum in my mind. You see the same things popping up over and over again, so these are the things we really want to be focusing on, and these are the tools and ways we can focus on them. Okay, next slide. And then finally, the 7 features of unnecessary excessive drug use that I like people to kind of walk around with in their head. If there's no apparent indication for the medication, it's got to be questioned. If it's a duplicate medication, has the same effects as another medication, why are they both being used? Does it interact with other medications which may decrease their effectiveness or enhance a side effect that's dangerous to the patient? Is the medication really contraindicated to that person? Is the dosage inappropriate, too low, too high? Is it one drug to treat the adverse effects of another drug? And if you stop this medication, is there likely to be improvement following discontinuation? That's a really good sign that the medication probably is being harmful and not helpful. And then the last slide, please. I always like to close with this quote from 1990 from a mentor of mine, Ron Stewart, who said the trend of multiple drug use by elderly people will likely increase in the future as a result of an increasing burden of chronic disease and success of researchers who develop new drugs. He is very correct. I could reissue this statement in 2018 and it would be correct in another 30 years, I'm afraid. So with that, I want to thank you for your attention, and I will turn the presentation over to Dr. Tom von Sternberg, who's going to talk about more about medication use by older adults. Thank you.
Thank you, Todd. Next slide. So we really want to help this presentation relate more to your roles as care managers, care coordinators, health plan individuals who are trying to get their hands on how to look at patients at risk for these issues. And then again, at adverse drug reactions, adverse drug episodes, again, are what we're trying to avoid. Next slide, please. There is really no better way to do that than to look at a couple of case examples. And so we'll talk about a couple of patients, both in my presentation and in Donna's coming next. But Mrs. Smith, a patient that you all may well be familiar with, she's about 87 years old. She's been falling. She's complaining of joint pain. She's got some memory issues. She's, on a good day, already impaired with her self-care and her ADLs. She had an episode of rectal bleeding a couple of days ago, didn't tell anybody about it. She was in the ER just last month because she fell and had a laceration. Her blood thinning levels were outside the recommended range. And then she was also given another drug for a new condition that also had some impact. Next slide. Clinicians that manage complex frail elders are pretty used to seeing this view of a patient. This is the conditions, the ongoing chronic conditions that Mrs. Smith is trying to manage with her team of doctors. I also would point out, as we're talking about this work, this is absolutely imperative that we know there are multiple clinicians involved in helping manage complex frail seniors, especially our dual eligible population. Specialists, primary care, mental health providers, and as well the number of clinicians involved during transitions, hospital medicine physicians, transitional care physicians, etc. So a list of 20 chronic conditions, of which each of them is substantial on its own. Next slide, please. As we already mentioned, each of them have an indication for a potentially effective medication, but also a medication that has potential both side effects and drug-drug interactions. The role of us in this space of care coordination, care management, and looking at populations is, well, boy, I can't know details about each of these drugs, but as we just heard, it's both the class of drugs and those that have the greatest risk to try and have us feature and be paying attention to. And so from that perspective, the idea of, boy, when we're at 20 medications, including prescriptions and non-prescription medications, it really does kind of give that example of this is an individual in a situation that does really deserve and would benefit from that assessment. Next slide, please. So the idea of the challenge to that primary care physician, his or her specialist colleagues, and our hospital colleagues is this individual patient has themselves 20 chronic conditions. Therefore, medications then simply multiply. The difference in how the body responds to medications changes over age. Another important perspective to have as you become more familiar with the world of geriatric medicine and caring for frail elders, there is really not strong evidence for the kinds of results and impact that medications have been shown to have in a frail older population. So much of the decision-making about choice of treatment is not based on evidence for that 85-year-old, but it is presumed to have similar impact as it was studied on a 60-year-old. We also absolutely must remember that the capacity for any individual to comply, understand, remember, and take that full array of medications simply is not possible. And even with Medicare Part D coverage, and even in a dual eligible population that has their medications paid for, costs and burden continue to be a struggle for patients to get their medications in a timely fashion and to even understand which medications are even due for refills. And always, supplements and over-the-counter medications recommended by clinicians, but also that patients and families on their own take, have to be considered. Next slide. Some statistics that reinforce what you already heard. Again, this is simply where the action is for polypharmacy and multiple medications. And that massive portions of the population that we are coordinating, that you're helping to care for, are in this space of multiple medications with over-the-counter use, and the idea that there are additional supplements out there that we need to be aware of. And this is evidence from 2010, but again, if it was studied more recently, we would see the same numbers. Next slide, please. Definition for the day, polypharmacy is 5 or more regularly prescribed medications. And that by direct result, that leads to potential for unnecessary medications, and that therefore the harm and the risk is there. So I think, again, we use 5 as a cutoff. People can have issues with medications that are less than 5 total, but still, this is part of our framework that we try to emphasize. Next slide, please. The fact that such a majority of our patients are on these larger arrays of medications and results in what we've talked about, the one emphasis here, I think, is quality of life and simply burden. Next slide. This issue of quality of life and burden, again, fatigue, constipation, drowsiness, poor quality sleep, difficulty with self-care, lower energy, bowel and bladder issues, and cognition. These are the kinds of things we'd like to lessen for our frail elders. Next slide. So again, the idea, no surprise, massive percentages of this population are experiencing adverse events because of medication use. Emergency room trips, hospitalizations. I think this last dot point is quite sobering. 30% or more of elderly patients who are admitted to the hospital are there because of the contribution of an adverse drug event. Next slide, please. So as we showed in our previous, kind of that purple slide, if you remember those classes of drugs, again, no surprise, the recurring theme is there are higher risk medications than others. And that our role from a care coordination perspective and that population view, again, is not to become experts in anticoagulations, but know that those are the medications that we want to emphasize to get patients exposed to drug reviews, pharmacy support, and attention to the risk of transitions where those medications can be changed. On the right side here, though, very important, the idea of the most dangerous medications, these three clearly have the highest risk. Warfarin, being an anticoagulation drug used for stroke prevention, is extremely challenging to use properly and safely. Insulin for diabetes, commonly used for decades, but for frail elders can have significant consequences of low sugar and consequences like that. And then digoxin, a medication used for heart rhythm difficulties, again, high risk for side effects, although can be effective to help patients with heart conditions. Next slide. So Mrs. Smith, is she at risk for adverse drug events? And everybody has already made their decision by saying yes. She's got more than 6 chronic diseases. She's on massive different medications. She indeed is struggling with renal function being diminished. Her nutrition more than likely is suffering. And she's had previous adverse drug events already. Next slide. Why is she at risk? Because she is navigating her 8th and 9th decade, accumulating all of these chronic conditions with well-intended clinicians offering up potential treatments for each of those conditions. And again, multiple prescribers in that same vein. I think, again, one of our strategies has to be to consider how we can have clinicians talk to each other more, and the role of care coordination and care management can really help emphasize the fact of we have to get some better cooperation amongst a variety of people involved in these prescribing arenas. Physiologic changes are important. The changes that occur with aging about diminished capacity and tolerance to medications. Decreased reserve capacity means the tolerance to any end organ that's being treated simply doesn't have the reserve to put up with stresses of either medication or the illness itself. Next slide. Our body changes our fat, water, and muscle distribution as we age. That affects how medications impact our bodies. Our brains become much more sensitive. Conditions of heart, kidney, and nerve, again, those conditions lessen the tolerance to the potential side effects of other classes of medications not being used for those conditions. And that the idea of the same amount of drug in a frail elder individual will have a significantly greater effect than it will in a younger individual. This concept you've heard before, starting low and going slow, and again, reviewing that patient's list of medications. Are they on the lowest dose possible? And from the deprescribing perspective, as we've already heard, do they really need to be on that medication? Next slide. We pay a little bit more particular attention to the aging kidney because so many of the medications we use are metabolized and filtered and excreted by the kidney. And so that with normal aging slows down, and that impaired kidney function because of conditions like diabetes also results in more challenge. And so again, longer therapeutic effect and stronger side effects will occur. So with this background and some of the things you've been hearing again and again, Donna is going to take us through a bit of strategies of how to be more patient and family-centered as we try to engage with impacting the challenge we have with our frail elders.
Thank you, Dr. von Sternberg. That was super. Next slide, please. So like my colleagues, Todd and Tom, I'm giving you an evidence-based approach, and you'll be able to get some of these citations, I think, if you need them. But I really want to give you one that's based in practice in using real older adult stories to illustrate issues about taking medications, medication problems, and then how we might intervene. So Mrs. Ryan was a pretty common dually eligible patient that I worked with in California as a geriatric clinical nurse specialist and a care manager. She was an 82-year-old retired baker with COPD and an 8th grade education who was recently hospitalized for pneumonia, and she had a history of cognitive impairment, is on 13 medications, by the way, prescribed by multiple different providers. And when Nurse Donna comes out to see her in her home today, her mini mental state exam is 22 out over 30. So she tells Nurse Donna that she did not refill her inhaler because she couldn't afford the copay, and she stopped taking her antidepressant. Her son lives with her, and he is unemployed and does not seem to be helping with her care. And she's not able to tell Donna what the medications she takes are used for, and is not sure what she should be taking since she came home from the hospital. Since in the hospital, as many of you know, she was started on multiple new medications, and there was little time when they suddenly decided to discharge her. Next slide, please. So let's build on our thinking about Mrs. Ryan, again, going back a little bit to the evidence, and we will come back to Mrs. Ryan. So these are some of the personal and demographic issues that put older adults at risk for not taking their medications properly and for having medication problems. I will say that I'm going to talk a lot about personal factors, but what you will see is it's not just person factors, and I think both Todd and Tom alluded to this. It's really health system factors, provider communication factors, factors to do with how medications are dispensed and taken during the day. So there's these multiple sort of system factors that interact. Most of these factors you see are based on a systematic review by Rand Health and a systematic review by Gilad et al. In 2011. And most of these you will see in our actual case. So this one is about mental state. You'll see that many of the factors with mental state interact. We heard Todd talk about how the dually eligible have over twice the amount of cognitive impairment. And several studies have found that forgetfulness and memory complaints are one of the biggest barriers for older adults taking their medications properly, particularly if they don't have assistance of a caregiver. It's important, of course, to understand that these factors interact with the degree of assistance. So you can't just assess mental status, though that is critical, but you also have to look at who's helping them with their medication and what is their system. And another study found that a mini mental state exam, less than 24, is associated with problems taking the medication. And remember, our case, Mrs. Ryan, had an MMSE of 22. Next slide, please. So older adults also have physical factors that was found in the review by Rand and Gilad. And many of these physical factors are really related to not just physical conditions and number of comorbidities. And I think you saw that slide, which even wowed me from Dr. von Sternberg, that showed 20 different conditions. And again, that's not uncommon. We also see again that this is more common in dually eligible. So parsing out the physical factors can be more difficult and complex, but try to keep in mind knowing what their conditions are, but more importantly, knowing how these conditions impact their function, their physical function. Next slide, please. This slide may be one of the most important ones I show in terms of risk factors for not taking medications properly. And why I say that is because most of these are modifiable or able to be changed or supported with proper assistance and proper communications. Many of these are likely influenced by the relationship they have with their provider or with their health coach, which you'll hear about more later. So again, these can be overcome, or their case manager, as many of you on this call are. So for instance, just a couple examples. Several studies have found that patients who gave a lower priority to discussing their hypertension meds with their provider had more problems with them. Patients who didn't see their condition, whether it was diabetes or hypertension, as a threat had more problems taking medications properly. So it's not just giving them the medication, it's helping them understand about their condition, and we'll talk more about this later, but really understanding what matters and what their beliefs are and their attitudes towards their chronic condition and their medication use. Next slide, please. Here are a lot of other factors really, which I kind of threw together, but these really, again, are a combination of a few personal factors, such as living alone, whether or not they have a caregiver support, but a lot of these really are provider issues, communication issues, and system issues. So what is the complexity of the medication, pill delivery? Again, these are things that can be addressed, and we'll talk about that in a moment. And a major underlying theme of many of these is communication. We saw many of these in the case of Mrs. Ryan, that she had a caregiver but wasn't clear how much support she was getting from that caregiver. And what else? Low socioeconomic status and hospitalization in the past 6 months. So this issue of the transitions are critically important. Next slide, please. So what do we do about this? Again, I'll say that if you remember nothing else from my talk, if we don't start from understanding what matters, it doesn't sort of matter what we do. So pulling everything that you've learned together so far in terms of what medications put people at most risk, what conditions put them at most risk, what personal factors, but asking individuals what matters and understanding their beliefs and values around not just medication, not just prescribed medication use, but also why are they taking that over-the-counter medication? Why are they taking that herbal medication? So again, understanding what matters to them, what their biggest concerns are, and what kind of things are keeping them up at night. It's very, very critical in older adults to assess their mental status. You cannot know how much support they need or if they can take their medications correctly if they don't. My expertise is actually delirium and dementia, and I'll say that the brain, though it's one of the most important organs, sometimes we're embarrassed to assess it. So don't apologize for assessing mental status. Assess it. Also vision and hearing, which of course interact with the issues with cognitive impairment. Know how medications are accessed and paid for. Again, the case of Mrs. Ryan, you would think, and this was 20 years ago, but you would have thought, okay, you don't have $8 to pay for your copay, but for many of the dually eligible, that's actually a reality. Simplify instructions. Several studies have actually showed it's not just health literacy per se in terms of reading, but it's also many older adults or people with cognitive impairment have issues with numbers. So using images rather than numbers. Also technology. Next slide, please. This is an example of a person-centered approach, and I won't say a lot about this except say that we use these in our health system. So if you are deprescribing, you're trying to take people off unnecessary medications, you also have to say, okay, if I'm going to take you off this sleep medication, then let's work with you for sleep hygiene, figuring out, are you going to bed at 8 o'clock and waking up at 2 in the morning? Well, if you look at aging sleep architecture, that might actually be normal. We use this in particular with persons with dementia or cognitive impairment. So if they wake up at 2 in the morning and they're agitated, the nurse says, okay, I know what kind of things make you feel relaxed. I know what kind of things make you scared. I know what the family member you're most close to. This can be made on a PowerPoint slide very, very simply, and you can print them out. And it's actually, it says here that it's a form, but it's the ones that we use are actually a poster. And the other thing is the older adult can take it from setting to setting. So they can take it from the hospital to the assisted living to the skilled nursing facility or back to home. Next slide, please. This is just some examples of technology that you can go back and look at later. But I will say I think that the use of technology, particularly voice-assisted digital technology to remind older adults to take their medications is very important. A recent study by Chris Wazinski, this is a critically important study for nurses where she looked at individuals who were getting psychoactive medications for delirium, and she showed them when they would get agitated, she showed them a 1-minute video of family members reassuring them and calming them down, and she was able to significantly decrease their agitation scores. So, using technology to avoid inappropriate medications. Next slide, please. So back to the case of Mrs. Ryan. These are just an example of many things that were actually done for Mrs. Ryan that we've I hope this sort of brings together a lot that we've talked about. So the nurse conducts a home visit, addresses her mental status and memory issues, and she talks with Mrs. R about what she knows. She actually has her look at each medication. The other thing is, if she's opening her, can she even open the bottle of medication? Can she actually see the label on the medication, and does she understand why she's taking them? Is this something that she was prescribed when she was 45 years old and she never questioned now at 75 and 85 whether it's still helping her? A social worker to help out with very clear issues with Mrs. Ryan in terms of paying for medication, and also to look into other community aging resources such as transportation to get to her medications, home aids, and financial assistance. The pharmacist, again, can assist with a Deprescribing plan, as Todd explained and gave information about, and that's a great website, deprescribing.org. You can actually print out papers there to use with patients and consumers. And then the physician could consider a referral for medication therapy management, which is covered by Medicare Part D, to do some of these things, such as a medication reconciliation and developing a schedule that decreases the complexity of her 13 medications. And then very importantly, the care manager, who really pulls all of this together, assists with understanding the chronic conditions in the context of all of this, and might also help offer some non-drug alternatives. Next slide, please. I'll just say, you can go back to this slide later, I'll say two things of it, is remember to reinforce with older persons to never stop a drug just because they're on a list without first consulting their clinical provider, because again, they may need to be tapered, and they need to understand it in the context of everything else that's going on with them. On the right, you'll see an article. It's actually called How Should Nurses Use the Beers Criteria, and this would apply to the START-STOP criteria too, and you can access this at the editorial, so you can access it for free on helio.com. Next slide, please. So just to summarize, a couple of things that I think are really important in terms of safe and effective use of medications is to have a system that engages individuals and caregivers really as partners. Again, as partners, even persons with dementia, you may think, well, I'm going to talk to the caregiver. No, don't do that. Also talk to the person with dementia, or the person, talk to them actually first, or talk to them together. We also need medication lists that are really truly informative lists, that are also portable and consumer friendly. So many times we create lists that aren't necessarily friendly to the consumer. And then a team approach, which I think we've talked about. And that team can even include, in our case at Penn State, we many times work with engineers to think about how can we do this differently or better. Next slide, please. So I'll end and turn this over to Maricela, was saying that, and I'll also steal a quote from Don Burowitz from the Institute of Healthcare Improvement in his recent talk, where he said, the best way to address medication use is all together or not at all. This is truly one that requires an interprofessional, inter-team approach where we have cooperation, not competition, with a shared purpose. Next slide, please. So I am pleased to turn this over to Maricela Tejeda, who will give us some insight into health coaching. Thank you.
Yes, good afternoon, and thank you for the opportunity. Once again, my name is Maricela Tejeda, and I am a senior health coach for City Health Works. which is a community-based non-for-profit organization that serves as a link between the patient and the health system to provide the tools and services needed in order for the people in their community to take control on their health, their lives, and as a result, reducing health and medical costs. What does City Health Works do? City Health Works coach clients to better manage chronic illness, including diabetes, congestive heart failure, high blood pressure, and asthma. Coaching is done in the home or whatever is the most convenient for the client. It could be a local park, a hospital, or a community facility. City Health Works hire and train workers from the neighborhood to become health coaches. So they are chosen from their own neighborhood to serve their own neighborhood to be healthier. And because they understand their culture, they speak the language and their background, it is easier for the people to feel comfortable and follow through the program. Clinicians supervise a team of health coaches, which means that they do not work on their own, but they are supervised on a daily basis. City Health Works also use motivational health coaching and ongoing care coordination to provide clients with the knowledge, capabilities, and confidence to take control on their health. So tools are provided by the health coaches for the clients to take control in their health, in their lives, and also to advocate for themselves. City Health Works inform referring providers about urgent and routine medical, psychological, and social needs of individuals to ensure access to the right care from the right person at to the right time by escalating any issue or need of referral, including depression, to their provider through the supervisor of the health coaches. And here in this picture, we can see in action a health coach with a client and the doctor in a doctor's visit. Next slide, please. Health coaching and care coordination. Referrals and enrollment, they are done in two different ways. One is clinical referrals, and the other one is cold outreach via population health list, in which the person do not know the organization, know the program most of the time. So it is a coach's responsibility to present the organization and explain the program to the client with the hope that they are going to be able to enroll. The health coaching is done in three different phases. And the first one is the weekly in-person sessions when it's basically covering education. They go through disease acknowledgement, medication adherence. The first session is usually med reconciliation, where the coach has the opportunity to go to the home visit the client and check their medication one by one, what they are taking this medication for, the different milligrams that they are supposed to take in, and just make sure that they are following the instruction given by the providers for medication. They also help the clients with a risk reduction, symptom and control, and monitoring. Also healthy eating and physical activity, including a walking club that is taking place when the weather permits, twice a week for the clients to be able to meet other people with the same condition and also have some physical activity. And also health coping and support, including depression and support at home. The second and the third phases of the program is biweekly and monthly in-person or over the phone check-ins. And even though it's not including directly education, education is reviewed according to the need to reinforce anything that the client is lacking to make improvements. They also do escalation of urgent and semi-urgent needs, evaluation and management, also socioeconomic and psychological and psychosocial barrier, and scheduling and navigation support, accompany clients to medical visits, as we saw in the previous picture, and regular progress to the clinician about their goals and their any issues that they might have. Also, they accompany them to social services to reduce the stigma and ensure needs that are met. For example, if they need to go to and register to a food pantry because they're having issue with their food, or maybe to get some medical devices or supplies that they might need to better move in the house, those are referred by the coaches, and they accompany them to register and provide whatever information it is needed. And the last slide, please. And that is a case study that we have, and that is Mr. M. We can see that the doctor prescribed 1,500 milligrams of their diabetes management medication, but client only received 3,750 milligram pills from the pharmacy. Health coach contacted a health coach supervisor who called a certified case manager right away. Certified case manager emailed the client's primary care physician to confirm the correct dosage. Client's physician confirmed the 1,500 milligram dosage and realized that the script went over to the pharmacy wrong. The pharmacy gave the client a 15-day supply by mistake. Physician sent over a new script to the pharmacy with the correct amount of 60 pills. And that is the job of the health coach. They check everything. They report these issues right away to their supervisor, and their supervisor report this immediately to the provider in order to resolve the issue as soon as possible. And this is all. Thank you very much for the opportunity again and for connecting and paying attention.
All right. Thank you so much, Dr. Semla, Dr. Von Sternberg, Donna, and Maricillas for your presentations. This has been incredibly informative. Thanks so much for joining us today. With that, we have a few minutes now for questions from the audience. So at this time, if you have any questions for our speakers, please submit them using the Q&A feature on the lower left of the presentation. Type your comment at the bottom of the Q&A box and press Submit to send it. So we have a couple of questions that came in during the presentation. So I'm going to start with Dr. Semla. And this question came from the Agency for Healthcare Research and Quality in Maryland. And the question is that older adults tend to have many treating providers. What can be done to re-educate prescribers about stopping a medication they hadn't initially ordered? Why do physicians tend to be reluctant to revisit the medications, especially if there are side effects?
Well, I think there's a couple things there. First, it's really important that patients and their caregivers they have to act as their own advocate. And you cannot assume that because you're seeing 5 different doctors that they all talk to each other. They usually don't. So you have to take a list of all of your medications and show them to each one of them so that they're very familiar with what you're taking. And there needs to be one person who's really kind of in charge. The primary care physician is usually that individual who's sort of going to coordinate those efforts. So that's one of the things. And ask questions and have those questions written down before you go in to speak with the provider so that you don't forget them and make sure that they know you have these questions so they save time to talk to you about it. I'm trying to now remember what the second part of that question was.
The second part was just about how physicians tend to be, or why do physicians tend to be reluctant to revisit medications with side effects?
Yeah, the research tells us that, in terms of making changes to medications, I think you really have to hit home hard that this is a side effect that is really bothering you. You're having to take another medication to treat it. So you're being constipated. Now you're taking a laxative. That you really have to let them know that this is a problem to you. Second of all, physicians are more likely to make a change in the dose, Sometimes they'll change medications if another prescriber has prescribed, but they're often very uncomfortable doing that or even discontinuing a medication that another prescriber has started, even though there's no rationale for the patient to be on it. They're very hesitant to monkey with that.
Great, thank you. All right. And Donna, I'll turn to a question that came during your presentation. And Maricela, you may be able to respond to this as well. But the question is, what can we do as care coordinators to increase the communication between the physician and patient, especially if there are multiple doctors involved?
Yeah, I think that's a great question. I see it often because what I often see with older adults is they'll have one primary physician that they're seeing quite often, but then someone else put them on another one and they're afraid to hurt their feelings or to say, do I need to still be on this? I think trying to use that PCP or care manager as the to coach them to, again, sort of like Todd said, let them know what's happening. I think I just barely mentioned it, but, the medication therapy, MTM, through Medicare Part D has been found to be very effective in terms of getting people down to a smaller number of medications, to increasing adherence, and it's pretty proven to help that. So again, if they're coming up with obstacles in terms of multiple different providers, having one person step in and look at everything, I think is good. Another way is to have a coach go in, and I'll have Maricela talk about this, but have someone come with, because what often happens is they only have 7 or 10 minutes to say what their concerns are. So writing out their concerns ahead of time and maybe focusing on 1 or 2 things instead of 10. Those are a couple of things, and Maricela might have some ideas too.
Yes, I may add to that. We go usually with the patient to the appointments and make sure to know the doctor and to see what is the relationship and communication that exists between both. We also prepare the patients, the clients, before they go to their appointment to take a note and write down all the questions that they might have and all the concerns that they might have. And as you mentioned before, just pick just a few of them. Make sure to bring your medication with you, and again, any concern that you might have to the doctor's appointment, so it is easier and in a short period of time for the doctor to be able to listen and understand and try to assist in whatever is needed. And we are there in the beginning to help them, and then we train them and help them, providing them the tools needed in order for them to take charge and then to learn to advocate for themselves, so they don't need us to go to every appointment, as long as they know exactly what to do and what questions to ask and how to address the doctors, which want to help. They want to help, but they don't have that much time available for every patient.
Wonderful. Thanks for sharing your insights, Maricela and Donna. So I'll turn now to a question for Dr. von Sternberg, but others, please feel free to jump in as well. The question is, Dr. von Sternberg, you talked about adverse drug events and the physiological changes that can occur. What kind of regular monitoring by family members or the physicians is needed?
That's a really important question, and I think it gets to the idea of what's the structure of how often we want to have our complex frail elders seen and what should occur during those encounters. With the example of Mrs. Smith and Mrs. Ryan, clearly the need for those patients and families to be in connection with their physicians at intervals more than likely 4 to 6 times a year, maybe even more often. But typically monitoring of the metabolism of both the organ structures like renal and liver function, and also, though, drug levels when appropriate, that can be done usually once or twice per year. The exception is the blood thinner, Coumadin. That needs to be even much more closely monitored. But one of the ideas of, boy, why is it important to establish that consistent relationship with a physician? It is just for that very reason. Monitoring of those metabolic factors really important. And so I think that the sense of can one person do that, or should it, again, what about the kidney doctor, the cardiac doctor, the rheumatologist, and the primary care doc? Again, the hope is that they are understanding the fact that those tests are accessible by all, or at least communicated to each other. For organized care systems, that works better than for singular practices that are not aligned. And so I think your hierarchy of risk has to do, again, with what kind of care group or care system is your patient and family interacting with. Because the communication, as has been said, is so critical.
Wonderful. Thank you, Dr. von Sternberg.
The other comment I would make, referencing our issue about how to approach encouraging doctors to make some changes. I think one of the ways we as advocates for patients who are complex and frail gets down to what Donna emphasized so much, which is approaching a physician about what's most important to me or to the patient I'm advocating for is I don't want to be tired, I don't want to be constipated, I don't want to be dizzy, I don't want to take all these medications. What are the options for me? What choices do I have? Offering that, physicians for the most part will respond to those queries, I think, in a positive manner. The courage of stopping a medication started by a nephrologist, if the premise is, I understand that from what I've learned as a patient, family, or care coordinator, you know what, we have different goals and different endpoints for frail elders. Couldn't we consider stopping and seeing what happens? Patient and family are comfortable with watchful waiting. I think, again, that's where the physician can feel more comfortable if we focus it on what's most important. Otherwise, transactional healthcare visits, we get what we put into that. A transactional visit is numbers-driven and encounter-driven, treat, not treat, add more, what have you. So I really do think the transformation here has to do with, can we change the relationship of why a patient is being seen by their physician, and especially for our complex frail elders. So that is a really important takeaway.
Absolutely. Thank you for sharing. I'm going to turn now to a question. Maricillis, this came up during your portion of the presentation. It's a question from Johns Hopkins Healthcare in Maryland. And they want to know more about the qualifications for health coaches and what training they receive. Maricillis, are you still with us?
I'm sorry, I was on mute.
No problem. That happens to me too.
Yes, they go to very extensive training when they applied and they are accepted to work for City Health Works. And it's a special program that Jamila Hoy Rosas, which is our Chief Health Officer, is the one that put together that program, which is very intensive. So everybody that is hired by City Health Works, the first few weeks to a month, it will be going to very intensive training, which I went to school to get a certification, but this, which was about 6 weeks, really provided me more information and more knowledge and more confidence of the training and certification that I got from college.
That's interesting. Thanks for sharing that extra detail. All right, I'm going to turn back to a question that came during Dr. Semla's presentation. And the question's about how to help clients communicate their symptoms so that you can avoid prescribing the wrong medications if maybe a client is having a difficult time describing their symptoms.
Okay, that's a good question. I don't think I've ever been asked that. I think probably one of the things I would recommend is to write these things down as you're thinking of them, so that you have something to read back or show the physician or provider when you see him or her. That's probably the best advice that I can have, so that you've got a good description of what it is, as opposed to trying to find the words in the short time you have face-to-face with the provider. And I would ask any of my colleagues on the panel to chime in and offer what maybe their advice.
I think a classic example is pain, the word pain, and how, again, not getting clarity on that is important. The second issue around trying to understand also gets to not necessarily the symptom itself, but I think a second question to either make sure you're asking, or that clinicians should ask, is how does that symptom affect your day, your function, your quality of life? So it's linking the symptom to what's the consequence to it. And again, poor sleep, getting more detail about what that means, and finding out is there time for education about, well, napping and other hygiene issues, et cetera. So I think it's trying to get those two things connected, also very helpful.
This is Donna. I was just going to add, maybe keeping a diary sometimes too can be helpful, depending on what the symptom is. But I agree with describing, what does it do to the individual, not just as a symptom or a condition.
Yeah, that's a great tip. Thank you. All right. I'm going to move on to another question. We're getting lots of questions in the chat, so thanks so much for all the engagement from the audience. This question came from UPMC in Pennsylvania. Dr. von Sternberg, I'm going to have you address this question if you don't mind, and others can weigh in as well. But the question is that I've noticed that neurologists and PCPs prescribe opioids, benzos, and Neurontin, along with other medications for chronic illness. Why does this still occur when the PDMP, which stands for Prescription Drug Monitoring Program, is available for use? Also, how do care managers approach this with the prescribing doctors?
Great question. Those three medications that are listed are what Todd and I have, again, put in those categories of high-risk medications. The PDMP is a tool that physicians can use to see who else is prescribing controlled substances and high-risk, potentially addictive substances. That is a step that is taken, but typically it has to reach a certain threshold for a doctor of significant behavioral issues of the patient. I would simply say that seniors will often get a pass by clinicians because they're not necessarily as aware that addictive behaviors can occur in that older, frailer group. Having said that, I think our neurology colleagues and primary care will still think of benzodiazepines and opioids as reasonable treatments, but again, not necessarily taking that next step of understanding the long-term consequences. So we still have a lot of work to do for education. And again, it is right now, the standard of care is not viewing benzos and opioids and Neurontin-like medicines as high risk and dangerous medications. We're getting there. In many ways, again, we should view them now as weapons, not as helpful tools. Well-intended, but extremely high risk.
Sure, thank you. All right, Donna, I'm going to turn now to a couple questions that came up during your presentation. These came from the area offices on aging in Northwest Ohio. So they would like to know if anyone has a medication adherence or a medication management questionnaire that you could give permission for use of a nonprofit CBO case management program. They also were interested in learning more about that All About Me tool that you referenced and whether or not or how they could go about obtaining permission to use that.
Sure. So in terms of a medication adherence tool per se that I would recommend, I don't really have one. Now, Todd and Tom may. I will say again that that MTM has been shown to improve adherence. I know that Nikki Brandt, B-R-A-N-D-T, has written several papers about adherence, and I think she referenced some of the tools in her paper. But, that's not something that I use routinely, at least not anymore. So not so helpful there. In terms of the All About Me tool, we freely share that. I'm not sure how to get it to the 1,700 participants here. And the other thing I'd say about that is this is an older version. The slide is an older version, and we've actually changed it to make our questions more about what matters, what concerns you the most. And so because it's made on a PowerPoint slide, you can easily change it to meet, to meet your local context and your local setting and culture. The other thing I'd say is we print them we actually print them in bright color very cheaply, and they can write on them. We have had some places that said there were issues with HIPAA violations. We don't find that in the hospital setting if it's in the room. But if that's an issue, you could make it a smaller form or some way where you protect their privacy if that's an issue you have. But, there are many versions actually of All About Me boards. This is one of ours. We also wrote a paper about the case example of how we've used it in the past, and you can access that for free, again, on helio.com. Hope that addresses that.
I'll add a comment about the adherence question. I find that it's best to find out why the patient is not being adherent to with their medication, and then look for an intervention that addresses that, as opposed to some places they'll just you get a pill box, get an organizer. Well, that works if you have trouble keeping your medication straight and don't remember if you took your medication this morning, and you can look and see if the box is empty. But unless it has a built-in timer, it's not going to remind you to take your medication. So I think that's really important to look. Is it financial? Is it they just don't believe they need that medication or that much medication? Is it they don't like the way it makes them feel?
Yeah, I would maybe just add to Todd's thing in saying that, several studies have shown that. So, everyone's trying to find the perfect pill reminder, particularly with technology. And most of that literature is very conflicting because of what Todd just said, and that is that people aren't taking the time to understand what's actually causing the non-adherence, for lack of a better term. And non-adherence, by the way, is often not a good term because it lacks understanding of what might be going on.
I think it's also important to remember that the evidence would show that once you get above 2 medications taken more than once a day, your risk of a gap is up by 50%. And in terms of how that's going to our patients simply cannot comply with the complex regimens we've given. That helps us in 2 ways. One is, one of the parts of the language of how to engage with clinicians is this individual is not taking this medication and cannot take it 3 times a day or 4 times a day. This individual cannot manipulate the inhalers that you've offered for their COPD. What is available for simple, or can we at least recognize, since they're not taking it, why not have a pause and a watchful wait? I think that's part of the platform for engagement of letting people express, I can't get this done. And that's the care manager's role, is to, again, advocate in that space, to then be another voice of best intended, but your Mrs. Smith really cannot take 36 different doses a day.
Great. Thank you, everyone. That was really insightful. We have a couple more minutes just for a few more questions. So, Maricela, I'm going to turn to a question that came up during your presentation. And I don't know if there's one solution to this, but maybe just from your perspective, how can family advocates or health coaches best deal with the difficulty in reaching the physician directly? In our area, it seems like there's just an 800 number to call. One has to be on hold for a long time, and then maybe we can talk to a live person. Getting to talk to a doctor is becoming a real challenge.
Yes. What we do is we use champions, and we choose whoever is close to the client. It could be a relative, it could be a best friend, or even a home attendant if they live alone. We try to work along with them. There are different ways to help, and is to provide them with the right numbers to call and in the departments. And also, we have our supervisor, as I mentioned before, that whenever we have an issue or a question from our clients, it is escalated right away to the supervisor. So in this case, if there is an issue, scheduling an appointment, we help them to navigate through the system. The supervisor will usually send a message to whatever provider or social worker or case manager that they need to contact if there is any issue with it, and we will do that through our supervisor. So as I mentioned before, the health coaches don't work alone on their own. We are supervised very closely, and we are the bridge between the patient and the health care system.
Great. Thank you, Maricela. We have a number of questions that came in. We have time for just one more question, and then we can follow up with all the other questions online. We can post the answers on our website. This question came from Washington Residential Care Services, and I'll kind of direct this just to the broad panel discussion, and whoever would like to respond, please go ahead. The question is, do you have any recommendations for working with individuals with mental health disorders to ensure the safe use of medications?
Well, I think it's important to determine whether or not that individual is capable of being responsible for their medications. And there may be times when they are, and there may be times when they are not. And is there somebody that can be identified who would be responsible for those medications, whether it's a family member, a friend, a roommate, someone like that, during periods of mania, for example?
I think individuals with chronic persistent mental illness who are living independently in the community, extremely challenging without there being an advocate or a frequent way to check in on them. Technology such as reminders or prompted dispensing devices can be used, but again, based on that degree of mental illness, they may not respond. Individuals in residential communities, I think, again, in that respect, you've got a much better ability to connect, monitor, reinforce, and be aware where there are gaps. But I think we all will struggle with the mental illness, or again, the individual with dementia who lives alone, who has no caregiver support. How do we ensure adherence or consistent follow-through with medication regimens? The answer.
Yeah, those are situations we've used medication trays or pill boxes that are exchanged weekly, by the pharmacy, so you have some sense of what's being taken and what's not being taken, provided it's an honest tray that the person doesn't just throw them away. But those are some things that can be used, but again, it doesn't work for every patient.
All right, thank you so much. At this time, if anyone on the line has any more questions or comments for our wonderful speakers, please feel free to email them to us at ric@lewin.com. And for more information, you can also find a list of resources mentioned during this presentation by our speakers on the last slide of this presentation. And we'll also plan to post this to our website along with other resources that were mentioned during the Q&A discussion. So before we conclude for the day, we'd just like to invite everyone to join us for the next webinar in our 2018 Geriatric Competent Care webinar series. It's on supporting older adults with substance use disorders. And a link to register for this webinar is on this slide, and we also have more information about it on our website. The slides for today's presentation, a recording, and a transcript will become available on our website shortly. And at this time, the post-tests for this webinar are now open. Additional guidance about obtaining credits and accessing the links to the post-tests can be found within the Continuing Education Credit Guide in the Resource Guide on the left-hand side of your screen or at the Resources for Integrated Care website. Thanks so much for joining us today. Please complete our brief evaluation of our webinar so that we can continue to deliver high-quality presentations. If you have any questions for us, please email us at ric@lewin.com. Thanks again to all of the speakers. Have a wonderful afternoon, and thank you so much for your participation.